The panel will be made up of 4 people, including Kaye Jensen, who is the Director of Advanced Practice Registered Nurses, or APRN, practice for the Department of Veteran Affairs in Washington, D.C. She also serves as the National APRN Health Policy Liaison. She is past president of the American Association of Nurse Practitioner and is a practicing nurse practitioner. Her work focuses on nursing and nurse practitioner issues in international, national, state, and local levels.
So it's interesting to think about the interaction between those two. I want to draw, and I think we'll probably come back to this because it's a theme that that plays out in lots of different settings. But I want to draw Penny into the conversation. Penny has worked on this issue for 10 years now and has led efforts to implement full practice authority for advanced practice nurses nationally throughout the VA. So now you have in one particular setting looking at expansions in authority. And I'd love for you to talk a little bit, Penny, about what were the biggest challenges and barriers to implementation in that setting, and what did you do to overcome them? And I know you've been thinking about this a little bit more now as you look at the VA versus private settings as well. So can you talk a little bit about the successes in the VA, what led to them? And
Yeah, thank you, Allison. And I'm just going to I think it was a good segue from Ed and William in what we've gone through within VA. But to give you a little context, because the VA is kind of a mysterious big organization that sometimes people really don't, I don't know if we don't share information. We're usually in the news for things we don't want to be, but the things we want to be, we usually never get in there. So just a couple of things. So we are the largest healthcare system in the nation. And we provide healthcare to 9 million veterans. And our points of care, we have 1,255 healthcare facilities, 170 medical centers, and 1,074 outpatient clinics. So when you think about that, I mean, that's huge to try to take that on as a challenge to implement something as full practice authority for APRNs. We employ over 26,000 physicians, and as of just the 1st of November, we have 100,000 nurses and 6,000 nurse practitioners. So the NPs make up the largest segment of the APRN population. The CNSs are 285, and then we have 1,000 CRNAs. And just a little more context, as of May of this year, we had 5.2 million appointments just in May. So we see a lot of patients, and so for us, I mean, the proposed change was really to use our resources efficiently. And in VA, it's rather interesting. We can work on any license. So as an NP, I can have my Utah license, and I could actually work in Florida. So for instance, in some of our clinics, you may have 14 nurse practitioners, and this is actually a true scenario, which I did visit one of our clinics, and they had 12 different licenses in one clinic. So that's very difficult to keep track of who can do what and who can order this, and because all these practice acts, as you talked about, are very, well, a lot of them are different. There's some that are extremely restricted, especially in the Southeast. And so that was one of our challenges. We wanted to standardize practice across the enterprise. And then we were hopeful that that would decrease wait times in primary care, because when we started this back in 2014, 2015, you know, that's one thing we were in the news for. We were truly behind. We had a wait list. Our primary care patients couldn't get in to be seen. And that was something that also really drove this. And then the IOM Future of Nursing document came out. So that was really what started the entire ball rolling. We had to get a formal opinion from DOJ and Office of General Counsel. That took a year to see if we could really do this. And yes, indeed, we can dictate what our care providers do within VA. The only caveat is we could do that, and we could invoke federal supremacy, which states do not want to hear, but we could do that, which we did, except for prescribing controlled substances. That's the piece that's still a problem for us and a challenge, because DEA is a federal agency, and one federal agency basically can't trump another federal agency. So the controlling of the ordering of controlled substance still remains a bit of an issue. But some of the challenges we faced once we did get the go-ahead to move forward, it was really a huge, endeavor. We didn't expect to get as much push back as we did. Our stakeholders, obviously, NCSBN, we had to go to the National Councils of Boards of Nursing because we were going to supersede their practice acts in the various states, the medical organizations, and then the nursing organizations. And as Ed mentioned, I mean, we thought, well, we're going to improve access to care for veterans. We're going to be able to provide high quality care for veterans. This is all great. It's going to be cost effective. Well, you know, somewhere I will just have to say the patient got lost and the care and healthcare actually got lost because we faced a huge battle. There were, I just wrote it down this morning, 60,000 letters sent to Congress. And each of those letters that went to Congress drifted over our way to the Secretary of the VA. And we actually had to establish an office just to answer the letters that we received to change something that we thought would be very accepted because we were truly just trying to standardize care and offer more timely care for our veterans, especially in rural areas, and telehealth. As you know, we're the leader in telehealth, but unfortunately, if a nurse practitioner is trying to do telehealth from California and they need to see a patient in another state, California is extremely restrictive. So we had those issues as well. We couldn't utilize our APRNs to the highest level of their education and training. The license was extremely restrictive. Another challenge, you know, I would say Georgia was a challenge for us. We had built a brand new CBOC in rural Georgia, but Georgia was so restrictive. A nurse practitioner had to have a physician within a 40-mile radius of that person. You had to have 2 collaborating physicians on record. Your collaborator had to be someone with a Georgia license. And in VA, as I mentioned, we could have any license. So one of our problems was we could build these great CBOCs, but we couldn't staff them. So all in all, there was a lot of pushback on the Hill. And because our regulation included CRNAs, we got a lot of pushback. And so it was a battle. It was a huge battle. When we did get the regulation written, it took a year to write it. It went into the Federal Register. We got 223,000 comments. So most the VA's ever gotten on anything. And so we had to address those comments. Unfortunately, the CRNAs were dropped after the proposed rule. And when it went back in as a final, they were not in the regulation. But we were able to get full practice authority for nurse practitioners, the clinical nurse specialists, and also nurse midwives, which we didn't have any of, but I included in the regulation because I thought we're seeing a lot of female veterans. We need to add the midwives. So I'm happy to report we actually hired our first midwife in Cleveland, and she's privileged as a midwife in that facility, and I think there will be many more. And then I just also want to say that this is really great timing because I'm just so proud of this. Oh my gosh, it's been such a struggle, but implementation wrapped up last week. So every VA facility in the United States has full practice authority for NPs, CNSs, and nurse midwives. That's a huge endeavor. The bylaws, we had to change the bylaws first, and obviously when the medical bylaws are amended, that has to go before the medical staff. And that was one of our barriers, as Ed, talked about. That was, there's people who want the status quo. They don't want to change. And to move that forward was a bit of an issue. And now, since we have moved it forward, there were 17 facilities in the United States. I think you can imagine what states they were that refused to move forward. Dr. Stone, who was our executive in charge, actually issued a mandate last fall. And everyone that did not move forward had to move forward by the end of the fiscal year, which was September. So I'm just proud to report that we're there. I think one of the biggest issues, I will just say, I know I've taken a lot of time, was it became a financial issue for private sector. But many in private sector medical organizations viewed this as it would trickle out into private sector, and it became really a financial battle. So I think that, standardizing care was the key, really what we needed to do, and we were successful. But it's taken 10 years, as you can see, and it's been a battle.
Penny, maybe I'll start with you because as you've looked across different states and tried to implement, I'm sure you've heard the full range of possible reasons for resistance. So can you talk a little bit about what you've heard, what you think are valid concerns, how you address them to move past them?
Yeah, so you're exactly right. So a lot have been physician concerns, and it's usually been in the Southeast, especially. I don't know. I think different parts of the nation, things have just, well, they've been status quo. They haven't moved forward as some of the other states have. One of the biggest concerns, and really a lot of the physicians, and don't get me wrong, I mean, we work with a lot of physicians, and truly, I love working with my physician colleagues, and they've always supported NP practice. But one of I think the myths is a lot of the physicians thought that we were going to replace them. And they thought the VA was moving forward to do this so that it would be a cost savings to them, because obviously our salaries are lower than a physician's salary. And so those are some of the issues, that we were trying to get around. And the incident I told you with Georgia, we just want to staff that clinic that we were able to. And I think the other thing was, it was interesting. Our own APRNs, I mean, we did a pre-evaluation just to see how they felt about it. And so we evaluated our own APRNs. We evaluated hospital directors, nursing directors, physicians. And it was interesting, and I think this is pretty basic, and we're talking about full practice authority, but people didn't know what it was. And then they were uncertain. And they thought, I mean, some of our own MPs thought, I like working with Dr. Johnson. I don't want to not be able to ask him a question. And so I think one of the words we really changed in VA is we consult with one another, because collaboration, the meaning has changed because of all these states that require collaboration. So I think those are some of the major issues that we actually had to deal with, and that and again, the physicians thought the MPs were going to be doing things that they were not trained and educated to do. And some of the examples I would get would be amazing, like, full practice today, doing a nephrectomy tomorrow. And I was like, do NPs do nephrectomies? No, we don't do nephrectomies, and nor will we ever, because that's not what we do. And so I think, just truthfully, there was a lot of lack of education for everyone. And so I think that was one of our biggest challenges, is trying to engage people, but also educate them on what full practice is and what it isn't. And then a lot of those safety concerns went away, because we're not rogue NPs starting our own practices. And that was one of the things too. People thought we were going to hang up our own shingle in the VA and start our own clinics, which is obviously would never happen. A lot of times, a physician may work in primary care a year or two while they're waiting for a fellowship to open up. But truly, they don't really want to stay in primary care. And there probably are some, but really I believe it's a financial issue. But also, we in VA, that was actually one of our talking points when we had to testify in front of Congress, where really it frees up the physician to do things that they can only do, that they're trained and educated to do, that really that we as nurse practitioners can do.
And I want to congratulate Penny for getting a national rollout on the VA changes, because the first implementation was highly regional in the VISNs and was not in close to uniform, and I was afraid it would never happen at a national level. So I think that's wonderful. But I also want to point out that the authority that came to the VA was in two areas. It was scope of practice and it was in telehealth, and that wasn't accidental, because the two really are linked and go to, among other things, your point. COVID changes give us an opportunity to alter the presumption. The presumption has been up to now that we will not liberalize scope of practice, or for that matter, telehealth, unless you can bring us data proving that it will be safe and not cause any other problems, and will indeed expand access the way you claim it will. Well, we've made all of these changes, and we've made them quickly, and the VA actually is a wonderful leadership position here. I think going forward, the presumption should be we're not going to go back unless someone who wants to go back can bring us data proving that this was a problem. I think we've studied primary care because that was the path of least resistance in some ways within the communities that would otherwise oppose. There are workarounds everywhere. They are non-transparent, they're hard to study, they are themselves suboptimal. And it's only by being explicit about the ways in which we have done these workarounds, call it an odd form of civil disobedience, that we're actually going to get. And part of COVID authority, it's been interesting. It's only been in a couple of states, but I think it matters, has given hospital settings more flexibility internally to accommodate and vary license categories. And I think that's really essential here. Without raising huge controversial issues about institutional licensure and whether institutional licensure can bring institutional accountability, I think the fact remains we use all sorts of health professionals to deliver all sorts of specialized services. We just don't like to talk about it.
Our specialty care clinics, they have a robust group of very talented NPs and CNSs who work in that area. Something I think is really interesting for us, so me, because I've always worked in the West, because I was born in Wyoming and I'm in Utah, so I've always had full practice. And so it's been kind of an interesting thing for me because I've been privileged. I've been privileged since like 2003. So that's been a big change for people who've been on Scopes practice. A nurse practitioner in a ER was able for their scope to order chemo. Why was that in there? And I see Bill smiling, so I'm thinking that I'm just wondering, are you agreeing with that, or what are your thoughts?
Oh, I'm very much agreeing with it. I think it's something I'd love to see more of the VA literature study and explain, because it's one of the many areas. I mean, the medical staff governance, as Allison and everyone else kind of knows here, is professionally important, but it's really vestigial, and it's caused all sorts of problems as hospitals have changed their governance mechanisms, and as sort of the production of complex clinical services modifies itself to do better with a more complicated staffing mix, and perhaps to address social determinants and things like that. So I think there's so little attention that's been given to medical staff procedures in the modern era that I am thrilled that you're doing this.
And I want to turn back to a theme that has woven through today, which is how COVID and trying to get people care during this pandemic has caused a seismic shift in a lot of these different areas of law. And I want to ask you all what you've seen that you think has been sufficient response, and what more needs to be done in your opinion. So we are heading into a really rough moment now as the numbers start to peak and hospitals are reaching capacity again. And I think, let me start, Ying, with you on this one, because, as we think about this, especially from the perspective of vulnerable populations, what do you all think has been enough? And it could be, categorically what has been enough, geographically what has been enough, and what more would you want to see happen in the coming months? So Ying, starting with you, please.
Yes. On the so far 21 of 28 states with our full NP scope practice regulation have temporarily suspended all restrictions or waived the selective restrictions in response to COVID-19. So that gives NP more independent authority to practice. So this indicates states recognize that lifting these restrictions is urgently needed to increase capacity to respond to the growing COVID-19 pandemic. It may also create a condition in which states acknowledge the impact of these restrictions, especially on vulnerable populations. So my move to permanently remove these restrictions. At the end of the September, California passed the legislation to grant NP independent practice authority. So I hope more states would see the effect and so follow the footsteps of the California and to expand scope practice for NPs and remove the restrictions for NP practice.
Ying, do you worry that this kind of regulatory shift might mean that poor, vulnerable patients of color are shuttled in one direction, and wealthy patients with access are shuttled in another? So you can imagine that that poor Black patients have a harder time getting access to a doctor than they did before. Do you think that is possible? And if so, would it concern you?
I would say all these changes are creating some very positive impact.
Others' thoughts on kind of the question of access to care for vulnerable populations, for patients of color, or
Allison,
kind of your thoughts on COVID reflections more broadly. Bill, jump in.
Allison, let me invite you to modify your question. Obviously, talking about the inequities affecting patients is important, but so are the inequities affecting professionals and non-professional healthcare providers. I mean, one of the big lessons of COVID is not just the disproportionate burden on communities of color, but the disproportionate burden on healthcare providers of color. And these are the professionals we don't really pay attention to. I was just looking at some nursing home COVID-related mortality statistics where there has been basically 10 times the staff mortality among non-RN providers than among our providers. And that's not surprising if you understand the staffing mix in the typical nursing home, but we're not protecting those people. And we've been arguing about the license categories, and we've been, as my friend Marty Gaynor always focuses on, talking about access and efficiency and cost. And part of the injustice here, in my view, is not just injustice in terms of the lack of access and timely access and high quality for patients in communities of color. It's really how badly we've been treating the people who care for those individuals, particularly people who don't have the sort of income and education and political influence and license protection of a physician.
And so that's interesting. So I was going to ask you how you see that fitting into scope of practice or licensure. And so you think that the kind of the licensure categories or scope of practice provide some protection and and more kind of political voice than for other workers.
I don't think we have time to go into it in detail.
Great. Penny, Ed, last thoughts. We have about 2 minutes left.
Oh, so just last thoughts. I know, I wanted just to mention, so full practice authority for NPs, we knew it would make it laws. So we really, this helped with our telehealth efforts. I was just going to say we're averaging 84,000 telehealth visits a week, 14,000 telephone calls a week. So by removing that scope of practice barrier, we are able to practice across state lines, and we have full practice authority from facility to facility. One thing I do want to mention is the CRNAs, and I think it goes to what Bill again said. Some states have the strangest, regulations. And so in one of our states, and Dr. Stone actually issued a memo on April 21st to allow CRNAs who actually held licenses from full practice states to be able to work to the full extent of their education and training. So for instance, in one state, a CRNA can intubate a patient per their state practice act. We needed the CRNA in the emergency room to intubate. So we too followed the suit of the states to allow some of the providers that we have. Also, Directive 1899 allowed people to cross state lines as well. But the one last thing I will say, and some of you may not know, but we put an interim final rule into the Federal Register last Thursday, and it is actually, it's called Authority for VA Health Professionals to Practice Healthcare. And basically what this does is we're invoking federal supremacy to allow, and the APRNs aren't a part of this because we already did it, we really were the example, to allow other people in our system, so psychologists, audiologists, the PAs are in here, RNs are in here, to allow them to be able to work to the top of their education, certification, and training, and the VA will be able to write the scope for these people. So we want our workforce. I think the pandemic really woke us up to that, to be able to be mobile, and everybody to be able to work to the highest extent of their education and training. So thank you for asking.